For this video, we will be focusing on several different antibiotic groups that target bacterial ribosomes to inhibit protein synthesis, inhibiting bacterial cell growth and replication, and we will start off with our macrolides. So moving to our next slide. So for the macrolides, we actually discussed azithromycin in the antibiotic video in block 4. But this class of agents also includes erythromycin and clarithromycin, which I've also brought up in past videos just briefly in other contexts, but we'll touch on these agents again here. So the way in which macrolides work is by gaining access to the bacterial ribosome and reversibly binding the 50S ribosomal subunit. And it binds at the site in the ribosome where the elongating peptide chain in the P site is added to the next amino acid in the A site of the ribosome. And this binding by the macrolides inhibits this peptidyltransferase action and inhibits further protein synthesis. So this leads to generally bacteriostatic effects. So we'll prevent that further growth, and the infection will need to be cleared by the immune system, or natural bacterial cell death will occur. So in some cases and concentrations, they can be bactericidal, but generally these agents are considered bacteriostatic. Now, in terms of the spectrum of activity, it does vary some between azithromycin, clarithromycin, and erythromycin, but generally they all have some gram-positive coverage, some gram-negative coverage, including some anaerobic organisms. But mostly will be limited to community-acquired infections. But the bonus with these agents is that they cover those atypical pathogens, like mycoplasma, for example. And this is one of the classes that has been clinically overused and inappropriately used, so there have been significant increases in resistance, which is why it is always important, again, to narrow and tailor therapy once cultures are back to avoid overuse of this group of agents. So the primary mechanisms of resistance are bacterial ribosome alterations, either mutations or the expression of protective proteins, or there can be those drug efflux transporters pumping the antibiotic back out before it can reach the ribosome. Also, there can be the expression of enzymes that are capable of inactivating the macrolide. So in terms of pharmacokinetic considerations, these are one of the classes that is actually hepatically cleared. So no renal dosing adjustments. Now, if you recall, the macrolides are one of the important CYP3A4 inhibitors. In the mnemonic we went over in block 4. However, if you recall, this is only a concern with clarithromycin and erythromycin, because azithromycin does not inhibit CYP enzymes to a concerning degree. As for adverse drug reactions, there are the usual antibiotic concerns. However, GI distress can be very severe enough with PO or IV formulations that the patient discontinues therapy. But this is more so with erythromycin, which makes sense if you think back to its indication for gastroparesis to get things moving. So in addition, there is going to be a risk of QT prolongation with these agents. So they're typically contraindicated with other drugs that prolong the QT interval, especially in susceptible populations. So overall, this group of agents is pretty common and clinically useful for a number of infections and atypical pathogens, but again, appropriate use is key to avoid growing resistance. Now on this slide, we are also going to discuss clindamycin, which is not a macrolide despite the similar name ending, but it does fall into the lincosamide antibiotic class. And the reason I've included it on this slide is because its mechanism of action is essentially the same as the macrolides. So also, like the macrolide agents, clindamycin is usually bacteriostatic, but with some organisms and at certain concentrations, it may be bactericidal. And as for spectrum of activity, this is one of the biggest differences between clindamycin and the macrolides. So clindamycin has no gram-negative coverage, but does have gram-positive coverage and is a substitution for penicillin allergic patients depending on the infection. And it has great anaerobic and protozoal coverage. So usually if there is resistance to this agent, it is because of some sort of bacterial ribosomal alteration. So like the macrolides, clindamycin is hepatically cleared, so no renal dosing adjustments. And then as for adverse drug reactions, one of the biggest ones for clindamycin, even though it is not as broad spectrum as some of the other agents we have discussed, there is this risk for C. diff associated diarrhea and colitis. Especially this is increased with PO administration. And this is actually listed as a black box warning for clindamycin. So because of the risk of C. diff, there needs to be a fine balance regarding the use of clindamycin, since it does provide a lot of utility for gram-positive and anaerobic infections and in those with a penicillin allergy. So moving to our next slide. So now our next two agents are relatively less common and share essentially the same mechanism of action as the macrolides and clindamycin. So we will not rehash this mechanism of action, but remember we are still targeting that 50S ribosomal subunit in a similar fashion. So starting off with chloramphenicol, which is indicated for systemic use only for serious infections for which less potentially dangerous antibiotics are ineffective or contraindicated. So again, sort of a last resort antibiotic, like several other of the antibiotics we have discussed or will discuss. So chloramphenicol is a broad spectrum antibiotic. So it will cover a number of gram-positive and gram-negative organisms and is generally considered bacteriostatic. Now, with this broad spectrum coverage, the primary reason that it is a last resort antibiotic is because there is a significant risk of bone marrow suppression with this agent that requires very careful monitoring of blood levels and CBC. And this is listed as a black box warning for chloramphenicol. And this agent is also, as you can probably guess, a narrow therapeutic window agent. So this agent also comes with a number of other concerns as well, but this bone marrow suppression is the big one. So because of the serious risk associated with this agent and the need to minimize any resistance to this agent, because again, we don't want to inappropriately use it and infections develop resistance to our last resort antibiotic, it's important to be aware of this agent even though it is not as common. Our next agent for this slide will be Synarcid, which is actually a combination antibiotic of quinupristin combined with dalfopristin. And these are streptogrammin antibiotics, and they work in a similar way as the macrolides, clindamycin, and chloramphenicol. But the two components bind the 50S ribosomal subunit at two different sites, all still near this same site, to inhibit bacterial protein synthesis, and this leads to a true synergistic antibiotic combination, where alone these agents are thought to be bacteriostatic, but when combined can be bactericidal based upon the pathogen. So Synarcid is an antibiotic providing gram-positive coverage, but is reserved for multi-drug resistant or MDR organisms that are gram-positive pathogens, like vancomycin-resistant enterococcus, or VRE, for example, because there are usually more clinically useful options, and this agent is very expensive. So it also does come with adverse drug reactions, like infusion site reactions, which are going to require a central line. There is a high risk for C. diff associated diarrhea, and Synarcid is hepatically cleared and will inhibit CYP3A4 enzymes. So there's going to be a risk of drug interactions with this agent. So again, I just wanted to introduce this agent, which has a particular niche with its ability to cover multi-drug resistant gram-positive infections. But because of its limited utility and expense compared to other agents, it is not as common. So moving on to our next slide. Our next agent for this video is linezolid, which is an oxazolidinone antibiotic, and its mechanism of action is distinctly different from the other antibiotics we've already discussed in this video, despite them all binding the 50S ribosomal subunit in relatively similar locations. So unlike the other agents that inhibit the elongation step of translation and protein synthesis, linezolid actually binds the 50S ribosomal subunit and inhibits initiation, meaning it prevents the formation of the initiation complex composed of the 50S and 30S ribosomal subunits, the tRNA and the mRNA. So after binding the 50S subunit, it's going to prevent this initiation complex forming and prevent any protein synthesis from occurring. So this agent is a gram-positive targeted agent that is bacteriostatic against some strains and bactericidal against others. But notably, it covers a number of multi-drug resistant organisms that are gram-positive, like strains like MRSA, multi-drug resistant strep, and VRE, and can be an alternative to Vanco in these situations. And one of its greatest advantages to Vanco is that it has 100% PO or oral bioavailability. So we can easily transition patients from IV to PO regimens at discharge, ideally reducing length of stay, despite linezolid having a relatively higher cost. So for linezolid, there are going to be no dose adjustments, neither renal or hepatic, and because it is a static agent for certain infections, it may not always be the best options for very serious infections, which you would probably want a bactericidal agent for. So there are several adverse drug reactions and drug-drug interactions to be aware of and monitor for, such as bone marrow suppression, which is most common in those on longer courses and will usually resolve once the drug is discontinued. There is also peripheral neuropathy and optic neuritis risks. And as for drug-drug interactions, this agent is a weak MAOI inhibitor or a monoamine oxidase inhibitor, which we will get into more in Block 6, but when combined with other serotonergic agents, there is a risk of serotonin syndrome, which we have discussed a little bit before in other videos, which is a serious drug reaction. So overall, linezolid has its particular niche and may not be as common as Vanco, but does demonstrate clinical utility in a number of specific situations and has some advantageous pharmacokinetic parameters. So our next group of agents are the aminoglycosides, which include gentamicin, tobramycin, amikacin, as well as several others. And these agents actually bind the 30S ribosomal subunit and are thought to have a number of effects, but one of the most notable being their ability to disturb protein elongation by causing inaccurate translation of the mRNA template, giving rise to inaccurately translated proteins that are either truncated or whose sequence leads to dysfunction and eventually inhibits bacterial growth and replication. Additionally, this will be important later on for synergy, but the cationic region of the aminoglycoside will displace cations from the lipopolysaccharides, disrupting the cell membrane and essentially creating fissures in the membrane, resulting in enhanced aminoglycoside uptake, or in the case of synergy, other antibiotic uptake. So alone, these agents are bactericidal against gram-negative organisms, but can be effective against some gram-positive infections in synergistic combinations with things like beta-lactams, for instance, but no anaerobic coverage because they actually require oxygen for their initial transport into the bacteria. And one big advantage of this class of agents is that resistance is relatively less common than many other classes of antibiotics. As for PK, these are renally cleared, and they are narrow therapeutic window drugs. So therapeutic drug monitoring is key, and dose adjustments using the patient's pharmacokinetic parameters and drug levels is necessary to prevent the serious adverse drug reactions associated with this class of agents, including nephrotoxicity, which can be reversible, and ototoxicity, which is generally not reversible. And there are nomograms to assist with aminoglycoside dosing. There's also a rare risk of neuromuscular blockade and should not be combined with similar acting agents. So these agents have really unique pharmacology, like with their mechanism of action, potential for synergy, and important pharmacokinetic considerations, and appreciating these will be key for appropriately using and dosing these agents in clinical practice. So moving on to our last group of agents. So our last group of antibiotics for this video will be the tetracyclines, and these include agents like tetracycline, which is commonly abbreviated TCN. There's also minocycline and doxycycline. And these agents will inhibit bacterial protein synthesis by binding the 30S ribosomal subunit at the A site, preventing tRNA binding. So bacterial proteins cannot be elongated, and these agents are generally considered bacteriostatic. So the tetracyclines are the therapy of choice, usually for many unusual pathogens, including several protozoal and anaerobic pathogens, in addition to pretty broad coverage of gram-positive and negative aerobic pathogens. So resistance to tetracyclines usually occurs via drug efflux pumps, like we discussed earlier, where we pump the drug back out before it can reach its internal targets. There can also be the expression of genes leading to ribosomal protection. And this is not the case with all antibiotic classes, but if a pathogen is resistant to one tetracycline, then it is usually resistant to them all. As for pharmacokinetics, so this is going to vary some between the agents, like for renal versus hepatic elimination considerations and dose adjustments. So just be aware that this is going to vary within this class of agents. Same thing with adverse drug reactions and drug-drug interactions. So some will vary, but there are going to be a few that are generally applicable to all three of these agents. So these agents will chelate with cations. So they cannot be taken with calcium supplements or iron, for example, and should not be used in children, as they will also bind the calcium in bone, leading to permanent tooth discoloration as well as decreased bone growth rates. And these should be avoided in pregnancy as well. And they also come with a risk of photosensitivity. So commonly prescribed agents, particularly outpatient, with coverage of atypical and anaerobic pathogens, so again, sort of an antibiotic niche. So moving to our summary slide. So this concludes our discussion of antibiotics targeted at bacterial protein synthesis, and I hope this video has highlighted several very common agents as well as several that are relatively less common, but they're very unique, that you should become familiar with. And as I mentioned in the previous antibiotic videos, and I'm going to keep echoing this, I would encourage you to practice grouping these agents according to particular characteristics that you think will help you organize these agents in a meaningful way that will allow you to recall the clinically relevant information you need in practice.